So my name is Ari. I'm just going to tell you a little bit about vertigo. Vertigo obviously is a symptom, not a diagnosis, and I'm just going to talk a little bit about what do we mean by vertigo, how to assess it from a SHO point of view, and if you have a broad view of vertigo, then you probably can to manage most of the patients. You're probably going to get referrals from ED or other wards, usually medical wards. So let's see. Essentially, for anyone to keep the balance and being able to function, walk properly, and not fall over, you essentially rely on three systems. So one is a visual system, so you use your occipital cortex, and which is a visual processing, which it communicates with your vestibular system, which is a part of the inner ear and essentially acts as a GPS system to tell your cortex where your head is positioned and the proprioception. And that's mainly done via the cerebellum, and which again, it's got a certain configured neurons which tells you where tactile information through the peripheral nervous system to tell you to stand upright. Proper. So if you are, if somebody is referring, yes. So yes, there's three systems to be able to go straight. So as we touched on, vestibular system, which is the visual system, the eyes, and the proprioception, which is the cerebellum. So if somebody walks through the door and has got some balance problem, there is a problem with one of those three things. Interestingly, people who come in with vertigo, usually there is something wrong with their inner ear or the perception system, not a visual system, because it doesn't give them that classical room spinning around them. I think the point here is when you're taking a referral for someone, you're speaking to someone and they say, oh, somebody's coming with a vertigo, please come and see. The first question is it actual true vertigo? And I don't think you'd be insulting if you asked them to describe to what they've asked the patient and what the patient described back, because being unsteady or dizzy, it doesn't necessarily mean that you've got vertigo. So I think once someone is got a true vertigo, then it makes the job easier, because then you know where the problem is coming from. And actually, it's quite a true vertigo in the community is about 3 to 10% of all balance problems are from vertigo, and the most common one is BPPV, which is the benign positional paroxysmal vertigo, which we'll talk about. In terms of signs and symptoms, so a vertigo has to be a spinning sensation, be anything else, its nucleus, which is so vestibular nucleus, is in the brainstem, and it sort of feeds different inputs. It communicates with the visual system, so we'll talk about the visual ocular reflexes and why that's important. The sense of falling or disequilibrium is probably it's usually not an inner ear, or people feeling faint. Again, they might come in and say dizzy, and then this gets mistranslated to vertigo, and they want you to go and see the person. It's usually not vertigo. If the most important part of some vertigo is history, when it started, how it started, and is it genuinely room spinning around them? And actually, they can describe to you exactly whether it's going to right to left or left to right, or some people say it's clockwise or anti-clockwise. Some visual diseases can also give you a feeling of sensation that you're unsteady, so something called oscillopsia, which I'm not going to go into too much. And it's quite important to people's gait. Most people who come with true vertigo is moderate or severe, they can't even stand up, so it's a bit difficult. But if they do stand up, they always fall to the side that's the problematic areas where the vertigo is. And always ask those questions as well, because as an ENT doctor, you're assessing essentially the autology of patient. That's what I referred to you, the vertigo or the vertigilous person. So, and then those are the 5 questions which you all know. But yeah, as you want to ask about hearing, tinnitus, whether they've got an ear pain discharge or fullness, and then it gives you a bit more idea of what can go wrong. This is probably the most important bit of this talk, I guess, to how to examine someone. Full cranial nerves, obviously, but you all know how to go through it. It's always a very good idea to check Webers and Rennies as well, because the patient's acutely depressed and are vomiting, and they might not notice that actually their hearing is gone. So, but if you check the Rennies and Webers, that gives you an idea. Romberg's is an interesting one. Essentially, what Romberg's is telling you whether there's a problem with your cerebellum or whether with your inner ear, because from out of those systems, so the vision, the cerebellum, and the inner ear, so the vestibular system, you need only of 2 of those things to be able to stand up, although you be symptomatic. So by closing someone's eye, as they close their eye, you're taking away the visual system. So if they fall over, they get worse. That means that the vision was contributing for them to be able to stand up and compensate a little bit. And when you take that away and they fall down, it sort of tells you the problem is either with the cerebellum or with the inner ear. Gait assessment, that might be a little bit difficult. Again, maybe they don't want to stand up, but if they're younger, it's always good to get them to stand up and see how they fall over and how what they do. Testing of cerebellum, it's I think if you go through Danish, so dyskinesia, ataxia, nystagmus, so you've got intention, tremors, slurred speech, and hypotonia. These are usually vascular problems, which again, then hopefully it doesn't come under due to restriction of the ENT doctor. But as I said, because the initial assessment by someone is always not adequate as such, so it's a good idea to ask the person who's referring you to whether those things and what the results was. One thing that is generally not done at all, or is done not well, is something called a rapid head thrust testing. And I'll show you a picture of how to do it. And essentially what this tells you is whether if there's a problem with your vestibular system, so you've got a vertigo, there's a problem with the vestibular system. You want to see whether it's upper motors, is it a problem with the brain, or is it a problem with the nerve itself, or i.e. the peripheral issue. And then if you do this well, in ED, you can sort of essentially say somebody hasn't got a peripheral problem, so they ought to investigate further with an MRI, because they usually do a CT to rule out a hemorrhage, but most of the time the problem is that there is an infarct which gets missed. So I'll talk about that. And Ottenberger's test is when you ask someone to snap on their feet with their eyes closed. If they start spinning, that usually means that there's a problem with the labyrinthine system. So again, that can give you a little bit of information. And fistula test is when you sit in front of someone and then you press on tragus as you increase the pressure. Again, they started to having nystagmus. So again, that tells you there might be a communication between the inner ear and the middle ear. So that's a good test to do. This is the rapid head thrust tilt test. So so this is from a Lancet neurological paper, and again, that's one of the most kind of important tests that you can do. It's actually quite relatively easy to do. You sit in front of a patient, you hold their face, and you ask them to look at your nose, and then you move their head rapidly side to side, about 10 to 15 degrees. If the eye is essentially the saccade is conserved, and they keep looking at your nose whilst you do that, then that means that the problem is from the peripheral issue. In the B part, What they do is they follow the the eye follows the head. So as you move it, the eye also moves 10 degrees, and then they have to refocus. So the eye comes back, and they have to look at your nose. That's the positive test. So that's again the problem with the periphery. So B is the peripheral vestibular disease, and A is the cerebellum. So it's tend to be, well, it's definitely is the upper motor neuron. Now, so we talked about the balance problem and what vertigo is, which is room spinning, and that comes from either the inner ear or its pathway to the brain. So there's something wrong there. So we just need to decipher if it's a true vertigo. Where is it coming from? Is it the peripheral vestibular system? So it's the ear, it's nerve. And as you know, the cranial nerve 8 has got 3 heads. So you've got the cochlear nerve, which lets you to hear. And then you've got superior and inferior vestibular nerves, which are involved with balance. So if there's an issue with those, going down further up is probably not the peripheral issue. Central vestibular system, that's when the nucleus or the cortex is affected. So again, classically, things like infarct, strokes, or TIAs can cause it. These are the ones who come to me and they've got southern onset vertigo, which is not going away, and they call you and they say, oh, there's a problem with the ear because we've done a CT and it's ruled it out, but they still need to do an ECG because you're looking for AF, sitting, standing, blood pressures and so forth to have a look at it. So sort of broadly break it down to central pathology and then peripheral stuff. And then we just talk a little bit about the peripheral stuff and what they are. Right, okay, that's gone away. Good. And the peripheral stuff, the specific diseases are kind of things like Meniere's, labyrinthitis, PPV, and perilymphatic fistula, and vestibular neuritis, which we talk about, and then this stuff on this side, which are the schwannomas. This is a superior canal dehiscence syndrome. It was a disease described in 1995, an issue, and then this is where it's Tullio syndrome. Or phenomena is when you hear a loud sound, you get a sudden onset vertigo, tend to fall over. And it also means disorders and autotoxicities. Again, this is broad topics. By far the most common one, as we talked about, and someone who presenting a vertigo, they tend to have BPPV, so paroxysmal positional vertigo. So it's usually happens in older people. Things that can predispose it are things like head trauma. So if they had a head trauma months ago or years ago, then eventually down the line they might present with PPV. So it's always good to ask in history, and viral labyrinthitis. So for some reason, it can later on develop into BPPV. The important things about BPPV, distinguishing out, is kind of it provoked by head movement. It only lasts seconds, or less than a minute. So as soon as the head is still, the symptoms eventually go away, and that's basically the history of it. And then we'll go through it. You can confirm it, but it's quite a straightforward diagnosis to make. You can do it over the phone. Again, if the history is taken correctly. Why it happens, the calcium crystals, the otoliths, and they tend to move from the either saccales or utricle and move into the semicircular canals. So again, the structure of the vestibular system, you've got the semicircular canals, which again, there's essentially a system with a fluid in it and gives you electrical signals to your brain to tell you where your head is. In terms of the horizontal and the vertical plane of movement, they are governed by the utricle and the saccule. And then you've got this added 3D with the semicircular canal. So they do the same thing, but the saccule and utricle, they tend to be they're vertical and horizontal, and the displacement of these crystals from this acronostrical into this mainly tend to be a posterior semicircular canal. Again, that's sometimes a question in DONS. That's when you get the symptoms. Again, you hear people talk about this left-sided or right-sided nystagmus. So broadly, when you say nystagmus is left-sided or right-sided, you're naming the fast phase. So the fast phase is say you've got a fast phase to the right. That means that the problem is with the left ear, with the inner ear, because the slow phase is towards the left. Again, when somebody is telling you whether nystagmus is left-sided and right-sided, if you question them further, they tend to get stuck a little bit, and as how they tested it, and whether it was raised the fast phase, how did they sort of diagnose it, and what have you. So it's always good to question things further, and obviously you go and see the patient yourself. In terms of nystagmus that you get with BPPV, they tend to be a rotary nystagmus. Again, Dix-Hallpike, I'm sure you all know, so as you position the patient's head slightly extended and flexion as they go down, so you're stimulating the vestibular system, the nystagmus starts. So that's the vestibulocular reflex. So you can look at the eye and then see if he's quickly going towards the right. If they're looking to the right, then the problem is the left, and vice versa. It lasts less than a minute. Is usually done by your history and examination, then imaging is not required. Great majority of the time it's managed conservatively, but there's some patients who suffer so much that there have been different ways of trying to surgically making things better by cutting a vestibular nerve, so the superior inferior, or trying to block the posterior canal occlusion, which these are big surgeries, so we just try to avoid them if we can. And it's quite important to tell people about driving as well if they're cancelling them, because if the room is spinning around them, they can't really drive around. This is the Epley's manoeuvre. So you've got the Dix-Hallpike, which tells you which sides is the problematic sides, and the Epley's is essentially one step after Dix-Hallpike manoeuvre. Is you're trying to reposition this is the posterior semicircular here. This is this otoliths in here. You're just trying to reposition that. So this lady is looking to her left. So the head is backwards and laterally flexed to the left as you go down, and then you're trying to do an Epley's on the left. You rotate the patient to the right, and they usually end up facing downwards. And each step usually takes about 20 seconds. So you tell the patient to pick a point in a distance, and then the more they look in distance, the better, because the better they can manage this symptoms. Because as you go down, they suddenly get up, sometimes sort of vertigo with nausea and vomiting, so they're going to feel absolutely awful. So by keeping their eyes open, first you can look at it and look at the nystagmus, and then fatigable nystagmus. So the more you repeat this, the less nystagmus, rotary nystagmus they get. There's a good video on YouTube. I think it's published by BMJ. It's just there's a chap who's doing it, so you can have a look at that. And when you see patients, it's very important to counsel them, because they're quite terrified, because they know what's happening to them. And it's something that suddenly does come on. They think it's a stroke, especially if it's the first time it happens, so they come in. So once everything is ruled out and the history is suggested with BPPV, it's very important to counsel them. And I always give them leaflets. Guys and Tom, they've got a very good leaflet on BPPV, so they can read it when they go home. And there's these exercises, which essentially is Epley's manoeuvre you can do yourself at home, something called the Brandt-Daroft exercises. And then if your local trust's got one, you can just print one out and give to them if they don't get it on the internet. So that was a BPPV. In terms of BPPV, it's kind of mainly managed in GP practices, so you might not see many of it in an acute setting. but when they come in, it's just good to know how to manage it, and reassuringly, you know, it's not anything harmful. Meniere's. So this is a disease essentially which is caused by a excess of endolymph within the scala media, and that usually leads to ischemia and rupture, and then the perilymph and endolymph mix, which they shouldn't, and then that leads to the symptoms. And what you tend to get is a recurrent episodic vertigo. It's usually kind of once it started, you last about last hours, 2 minutes to hours, and then it sort of eventually get better, and tend to be repetitive. Another thing happens in Meniere's, you get a very specific hearing loss in the low frequencies, which again, these are the Python audiograms which they ask. It's tested in done quite frequently as well, and then it's diagnosed by history. You do your audiogram, also electrocochleography. Essentially, it's the way it's tested is you present a sound to the ear, and then you're assessing the cochlear nerve to see how it responds to different sounds in terms of electrical activity, and there's a specific pattern for Meniere's, and there's a slight female predominance, around 40s. Again, this gets asked a lot in DONS as well. So you, especially in the Viva questions, you get a picture of that, and they ask you to mark it. So is it cochlear here? As you can see, cochlear, if you open it up, it's about 30 millimeters, about 3 centimeters. Scala vestibuli and scala tympani, these two communicate, and this is this scala media. So that's as the pressure in the perilymph goes up, you get a ischemic area in stria vascularis, and it eventually leads to death of tissue, and then you get a ruptured membrane, and then these two fluids, which they should, you see, this is called a basal membrane. That sort of breaks down, and these two fluids mix up, and then they stimulate the wrong, because the currents are different, so they give you appropriate stimulation. And this is how the audiogram looks like. So this is the circle, so round for right, and it crosses. So this is left ear. So as you can see, the left ear, this conduction is pretty normal. So everything is about 20. Whereas in the right ear, low frequency is about 250 to 500. You get a dip, and then you get a slight recovery, which is come up around 30, which is not too bad, and then you get a dip again. So this low frequency loss classically looks like an inverted spoon, which is Meniere's causes it. And in terms of history, you're just looking for that triad of tinnitus and the fluctuating hearing loss and vertigo. So it comes and goes. It's because you're getting a hearing loss and a tinnitus, you automatically will do an MRI anyway to rule out acoustic neuromas. Acoustic neuromas, obviously, because they're slow-growing tumours, you tend to get a gradual loss rather than a come and go. But as certain times, as the tumour gets bigger, you get a bit of edema, it goes down, so you can kind of mimic a similar thing. So you want to rule out acoustic neuroma. And there are certain immune disorders which again can mimic Meniere's disease. So if you get a bilateral symptoms, then it's always a good idea to involve the rheumatologists. In terms of the Americans classify Meniere's disease, who's got it, who hasn't got it, in four categories. So possible, probable, definite, and certain. Again, they go through history and examination, and as you can see, what you look for is episodic vertigos lasting 20 minutes or more hours, and then you tend to get this pressure around the ear as well. Another condition which is quite similar to is a migraine, and actually most of the Meniere's, which are get diagnosed as Aminias, they're actually migraines. Because again, they tend to be episodic and they cause aura, all this ear fullness. So Aminias, this is actually, it's not that easy to diagnose. How do you manage it? Again, you might get, they get quite a severe episodic vertigo, and again, they sit on it for hours, and then they get tired and go, oh, I need to go to the hospital, and they tend to come to the hospital, and then you get a call from you, say, oh, somebody's been Aminias, what do you want to do? It's quite difficult because there isn't much you can do. The rule of oral steroids is not really proven. Some people say it does work. The Medrol dose pack, this is a stuff that's provided by Pfizer. They try to manage these acute episodes of vertigo. In some people, it does work. So if you're in an acute setting and they ask you, oh, you have to do something, that's something you can try, short course. And beta histidine is, again, another medication that you can start them on. And then as the patient goes to follow-up, they've already been tried on both these things. In a long-term plan, so you can try the low-sodium diet and the potassium-sparing diuretics. So you might benefit from thiazides and so forth. And the reason you're trying to get rid of the salt is those fluids, the endolymph and peripheral lymphatics, they're rich in potassium and sodium. So you try to reduce the counterflow, so the lesser the cation gap, the less symptoms you get. So that's the idea behind it. Things that work, again, try to prevent this and try to get some recovery. Intratympanic steroid injections, which Tom should be able to tell you that it works in some people. And Aminias are those people who actually, some of them get some benefit from it. And there are some documented papers of suggesting that. And then gentamicin, because it's autotoxic, some centers inject it because the patient had enough and you're just trying to kill the nerve to trying to manage the symptoms. But obviously, because gentamicin obliterates nerve, you can get rid of the hearing as well, which is not great. Surgically, things that you can do, broadly, again, breast antidote hearing destructive, so you take the whole thing out because the patient had enough, so you go and take everything out. The other thing is you're trying to preserve the cochlear side of things, and you're trying to decompress things, and you're just trying to get rid of the symptoms by cutting the vestibular nerve. The other thing, again, I think this is where the stroke and vestibular neuritis get confused, because again, some patients who come in who don't have any risk factors and are absolutely having a stroke, but because of poor assessment, things gets missed, which is not great. So vestibular neuritis is inflammation of the vestibular nerve. So you've got the superior inferior heads that it talks about. If it gets inflamed, it impairs its function. So you start getting this horrendous vertigo, again, room spinning around. And again, it lasts for days to weeks. So it's pretty horrendous. The reason for admitting someone with vestibular neuritis is because essentially they can't eat and drink because they can't sit up, and they've got such a severe vertigo. It's not episodic, it's not going away, it's very severe, and they're vomiting all the time. So they get dehydrated and they just need a bit of resuscitation for them to get to some sort of baseline so they can go home. So that's one of the reasons they might get admitted under ENT. It's always important to rule out the if you've got a sudden vertigo. Again, you should always think it's stroke, because that's something that managed differently with antiplatelets and so forth. The best gold standard is doing an MRI, and the CT is not as great because it rules out the hemorrhage, and most of the these intracranial events, they tend to be ischemic rather than hemorrhagic. Vestibulitis is not associated with hearing loss because the head of the nerve is different because you're affecting the function of the vestibular nerve. Labyrinthitis causes hearing loss. So when you get a inflammation of all of the cranial nerves 8, so it's hearing and balance, then that's vestibular neuritis. Otherwise, they're quite similar because labyrinthitis is almost it's vestibular neuritis plus the hearing nerve, so it's not quite similar. And they've got these patients, they've got nystagmus. Again, same thing, you wanted to for neurological assessments, making sure that you do all of the Danish and so forth. And I think we talked about the Romberg, so they tend to fall towards where the side of the infarct is. So you've got a right cerebellar infarct, you get this sudden onset vertigo, nausea, vomiting, you tend to fall into your right as they ask you to stand up. It's vestibular neuritis is a self-resolving condition, so it isn't again it's just about reassurance and what to tell patients. And into UK, again, there's a page on it about how to manage vestibular neuritis, and also NICE guidelines got some guidance for general practitioners about managing of vestibular neuritis. And it doesn't tend to be episodic, so you just tend to get it. How to manage it? So you can try to suppress the vestibular system. You can give them some promethazine or cineruzine, which switches off their vestibular system, and they tend to make people sleepy. So, but I guess that's one of the ideas that you've given it. Benzodiazepines work quite well as well. And then the resuscitative bits are you can give them some fluids. And one of the theories that why vestibular neuritis happen is viral infection, just like the virus affecting your, I don't know, essentially cranial nerve palsy. You can try to give them some, if they had a, let's say, upper respiratory tract infection before this happened, acyclovir might just reduce the prolong of symptoms. So it tries to enhance the recovery a bit quicker. And again, steroids, there isn't much great evidence for it, but because there isn't much else to give, you always give steroids to reduce the inflammation around the nerve to try to enhanced recovery. And then, so when we talk about Meniere's, said actually a great number of people who have migraines, because the effective the area of the brain that is affecting is the vestibular nucleus. They tend to get these symptoms, which they get vertigo, episodic. They tend to not have headaches with it, and then it lasts for a bit and then it disappears. It can mimic the Meniere's disease, but the hearing tends to be intact. So that's again one thing that can think about. And the management of it is quite similar to how you manage migraine in general. So you try to avoid things that provoke migraine. So you can start a diary, ask patients to write down if they've got any anything that provokes it. So, the classic stuff, so wine, chocolate, cheese, and what have you. And then you can sometimes give them some triptans. That sometimes works in the acute phase. And in terms of preventative measures, beta blockers are, again, there's some evidence for it. And these are the way you try. The International Headache Society is trying to classify, to give a bit of a routine to how to diagnose migraine. But this is job of a neurologist, not an ENT surgeon. But we can act as a diagnostician. The last bit is again the labyrinthitis we talked about. So the labyrinthitis tend to be more infective causes, because when you get a virus, they tend to be non-discriminative and affect the whole of the cranial nervate. So it's more likely that if somebody's got labyrinthitis, that they had a recent respiratory tract infection or any of these specific viruses, so mumps, measles, and hepatitis, and what have you. And it's quite important to always look at the ear of the cranial nerve examination. You look into eardrum and the postal, there's no middle ear pathology, things like cholecystomas, or you can get deal with glue ear in adults. Again, if it's unilateral, or to look at the postnasal space, make sure there's nothing growing there. And otherwise, quite similar to vestibular neuritis, as we said. And tell them not to drive, because if they drive and they crash the car and kill someone, you can get penalised. But didn't tell them not to drive. It's something we forget quite easily. I think that's it. So it's it's a terrible topic, vertigo, because it can be it's quite it's very unpleasant to deal with. But as you can see, in terms of peripheral causes, there isn't a great deal can go wrong. So it's about what medication to give and reassurance. That's it. Any questions? I think I still have some coal left in my laptop to answer questions if you want to ask. Otherwise, go and enjoy your dinner. All right, no worries. I'll sod off then. Thanks very much. Sorry about the I couldn't get it into. It was entirely my fault. I think I was pressing the wrong buttons. But for next time, hopefully, I'll be better to set it up. I'm not 10 minutes late. Oh, shoot, team.